A 12-year-old girl with type 1 diabetes is brought to the emergency department by her parents because of a 2-day history of nausea, vomiting, and decreased oral intake. Medications are insulin glargine and insulin aspart. She decreased her insulin dose at the onset of symptoms, but her condition has since worsened, and she now is unable to consume solids or liquids without subsequent vomiting. She reports feeling dizzy on standing. Medical history is otherwise unremarkable. She's at the 50th percentile for height, weight, and BMI. Vital signs are temperature 100.1, pulse of 118 per minute, respirations 27 per minute, and blood pressure 85/47. Pulse oximetry on room air shows an oxygen saturation of 99%. Physical exam discloses dry mucous membranes, delayed capillary refill time, and poor skin turgor. Palpation of the abdomen discloses diffuse tenderness with no rebound or guarding. The remainder of the physical examination discloses no abnormalities. Results of laboratory studies obtained on arrival are shown. The arterial blood gas shows a bicarb of 10, a PO2 of 98, a PCO2 of 22, and a pH of 7.2. Serum laboratory values include creatinine of 1.1, a BUN of 28, a bicarb of 11, sodium of 126, potassium of 4.3, chloride of 95, and a glucose level of 563. What is the most appropriate initial management? So if our student panelists could put your answers into the chat. It looks like everybody's answers have been put in. I'd be interested to hear the students' thought process as you read this, if anybody wants to comment.
So when you were reading the vignette, I think the thing that really stood out to me was that she's not doing well, and it really looks like she has DKA, especially when you look at the lab values. And you do note that they're rather abnormal, and she is definitely lacking fluids, which is why I agree with everyone's suggestions that you always have to start with a lot of fluid and insulin.
Great points. Any others?
One thing I always think about when I'm reading questions is if they give me a piece of history information, it's because it really matters. And so for a pediatric question, a 12-year-old coming to the ED opens up a whole range of potential complications. However, I know that a 12-year-old with type 1 diabetes is coming to the ED in a question set that immediately cues my mind to, well, what are the complications with diabetes?
Ben, you bring up a really good point about the construct of this item. If the faculty member who's written this question because they thought it was an important testing point, they're going to put the information in there that you need, and not put information in it that's going to necessarily point you down a different path. So I think that's a very good point. Anna, I think you had some thoughts too.
Yeah, I think when approaching NBME type questions, there's often a lot of important detail in the physical exam. So here, if I were reading this question on test day, I would highlight the dry mucous membranes, delayed capillary refill, because that starts to give you a sense of the status of the patient and also directs your thoughts for what the next step in management is going to be.
Great. Let us reveal the salient positives and negatives of this case, or you might call them red flags.
I think a lot of the panelists mentioned a lot of these things already. Some things here in red that are worth noting: that dizzy on standing is a historical component of this case that says she's orthostatic, she's behind in her fluids. Further in the case, there are physical examination findings remarkable or consistent with that dehydration, right? The skin turgor, dry mucous membranes, et cetera, and delayed capillary refill. I'll speak to the idea of dehydration. Someone already mentioned that this person is in DKA. I think the labs are indicative of that. The blood gas looks acidotic or acidemic, but the chemistry here shows a widened BUN creatinine ratio consistent with dehydration, an anion gap in around 20, and someone with an elevated blood glucose. So I think we've clinched the diagnosis to for the most part in terms of it being DKA. good for you guys. You've picked out the really salient points of this case that will lead you down the road, hopefully, to the correct answer and answer set.
So obviously her glucose is extremely elevated, and that's something else to be concerned about in terms of dehydration, because you know that when someone's glucose is that high, they are going to be extremely dehydrated. Her potassium is also low for someone who is in DKA, so that's important to consider when you're managing the patient as well, in terms of wanting to consider giving them potassium. And of course, the bicarb is low. That's, we kind of already talked about. Her arterial blood gas values. And of course, seeing a BUN that high is concerning also for dehydration, and you're worried about her kidney function.
Jennifer, you want to add something?
Yeah, the last thing was sometimes I look at the question too. So in this case, it'd be the most appropriate initial management. And that kind of makes you think that the question stem is not going to be it's not going to be a question of what is this diagnosis as much as a question of what to do later. And while you were reading the question stem, I was thinking, oh, like, could this be a tricky question? Is it straight DKA? Could it be appendicitis that they're trying to like hide with her history? And the no rebounder guarding really made me feel better. At least it's not perfect, presumably. So I think knowing that the question seemed like a simple next step helped with not overthinking the question too much.
That's a great point regarding the construct of these questions, Jennifer. A lot of times we are compelling your faculty, these item writers, to write these very rich vignettes and provide lab data. And sometimes the hard thing is to focus the question. Because if you think about it, when you prepare for an examination like this, you might see a case like this, you might think of a patient you've seen, but you can also probably envision 5 or 6 other questions other than initial management that you could ask about this, because there's so much there. And one of them could be diagnosis, like you said. One of them could be related to pharmacotherapy, specifically in management, or even next study in terms of management. One thing we wouldn't ask you to do is to do math. So calculating the anion gap is absolutely important in this case, but it's more important to realize that there is one, even if you do the math in your head, versus showing us exactly what your equations look like, as it were.
Because you asked specifically about the labs, I use them just as a cursory confirmation of, is this DKA? And so the first thing I looked at was the ABG blood gas, 7.2. I was like, okay, they're acidotic. And then I went and looked at the glucose and saw, okay, we have an elevated glucose. And then I was like, okay, let's just make sure this is slam dunk. Calculated a gap and said, all right, it could be something else. It could be asking about how do you treat her nausea, vomiting. But based on these labs and these cursory few confirmatories, that really helped narrow in the direction that was going to go with it.
If you had your way, or maybe you were the person writing this question, is there another study or lab that you'd want at this point?
One thing you could do if you really wanted to seal it would be to do urine ketones or serum ketones. But that's not necessary in this case to make the diagnosis, because you wouldn't get that on your initial labs anyways, unless you were anticipating DKA prior to ordering the lab set.
Great point. Another good construct point here is that you probably have absolutely enough just how this patient presented and the labs you have already to make that diagnosis. So putting more and more information that would add to your already existing diagnostic reasoning probably wouldn't be helpful at this point. So thanks.